So this presentation focuses on improved well-being, the safety of appropriate use through knowledge translation, and always knowledge strengthens the patient-centered care that we all aim for. And I'm presenting from Treaty 4, the homeland of the Cree, Saulteaux, Dakota, Nakota, Lakota, and the homeland of the Métis here in Regina. So the objectives is just to do a basic review of the buprenorphine products, kind of give an idea of why this is important, the prescribing trends that we're starting to see in Saskatchewan, and why you may be starting, and why the nurses on the floor and pharmacists may be starting to see more buprenorphine coming in, especially on those reconciliations that were talked about earlier this morning. And just some clinical tips. The intent of this presentation is to increase awareness of the appropriate use of buprenorphine. Detailed therapeutic use of buprenorphine for the treatment of opioid use disorder is not covered in this presentation. Once this presentation is posted on the PEC site, I usually go in and cut out this presentation as long as there's no objections, and I share it on the stewardship website so it can be used by educators across the province just to show to staff during education sessions or guide them to it on their own phone because it is a publicly available website. So the products that are currently available that you may be familiar with is the sublingual tablet. That's probably mostly what you're aware of is Suboxone. So it's the buprenorphine with naloxone, a 4-to-1 ratio. It is used for opioid use disorder and pain management. And that is the key of why we are likely going to start seeing more buprenorphine or Suboxone product when we're doing the med recs and seeing people coming in with that. A film product is now available, which is very nice. One huge problem with the Suboxone is witness dosing, and it can take up to 10 to 15 minutes for that tablet to dissolve underneath the tongue sublingually. The film dissolves within 60 seconds. We are actually actively working with the ministry and CADF to see if we can get that film product covered. Sublocade is another product that's available. It is for opioid use disorder only. It is a subcutaneous injection. And then there's a transdermal patch, Butrans. Likely those in long-term care are most familiar with that, and it is for pain management only. So the indications of why we'd use buprenorphine is opioid use disorder. It stops the cravings. It has an excellent safety profile, and there's early evidence emerging for the treatment of methamphetamine use disorder, which we have a high number in the province of meth use disorder. Chronic pain management, again, has a great safety profile, treats the pain well, increases function, and has benefit for quality of life, which when treating chronic pain, it's not necessarily the pain number, it's quality of life and function that we're aiming for. Buprenorphine has less risk of toxicity with higher doses, lower withdrawal symptoms, and less abuse potential. Cote et al. Have demonstrated the unique pharmacological properties that make it an advantageous option for treating chronic pain. That increased efficacy for neuropathic pain, which is a very difficult pain to treat, and other opioids do not target neuropathic pain if we have to get to opioids for treating that. Ease of use in elderly patients and those with renal impairment, less immunosuppression compared to other opioids. It has a ceiling effect for respiratory depression. So as the dose increases, a ceiling is reached and it does not have the respiratory depression impact that other opioids have. Decreased development of tolerance and an advantage of safety and side effect profile. Rafa et al. Reviewed 24 studies to better understand the efficacy of buprenorphine as an analgesic. Of the 24 studies, 23 showed that buprenorphine is just as effective as morphine, fentanyl, sufentanil, oxycodone, for the treatment of pain. So there seems to be a misconception amongst many in the community that buprenorphine doesn't treat pain, and I'm trying to spread the word that it does treat pain. It just needs to be split dosed and dosed properly. In Saskatchewan, we are seeing a steady climb in the amount of buprenorphine products being prescribed and dispensed. You'll see on the heat map on the dots that Regina and North zones have the highest per 1,000 population prescribing. Saskatoon comes in behind, and then Central, Far North, and then Southeast. And that's for all indications. That's just any dispensing, so, and any product with buprenorphine in it. Very basic looking at, because I'm going to go to a better slide, but buprenorphine works differently. It is a partial agonist at the mu opioid receptor. All other opioids that we use are full agonists, and this is a key piece of why it works differently. It limits that euphoria effect due to the partial agonist and ceiling effect, and then it has a long half-life and is cleared hepatically. The long half-life helps with any cravings if it's being used for opioid use disorder, but also reduces any withdrawal symptoms. This is a great demonstration in bringing together of the key pieces of buprenorphine that are advantageous. And this is from the US Department of Veterans Affairs. So it's a partial mu opioid receptor, so potent analgesia. Um, it has that ceiling effect, as I discussed, regarding the respiratory depression and euphoria, decreased risk of overdose. Um, because it is a partial mu receptor and it's very strongly attached to that receptor, it actually prevents other opioids, if they're taken, from attaching. So it has a safety mechanism there. Decreased addiction in the literature, tolerance, withdrawal, decreased constipation, immune suppression, hypogonadism. Long-term opioid use results in testosterone deficiency in males and hypogonadism, and decreased depression, suicidal ideation, anxiety, dysphoria. What we're actually seeing independently, and you'll see that below, is because it acts on the kappa opioid receptor, it actually can treat depression. And there's actually studies going on across the US and in Europe where they're using buprenorphine independently to treat depression to see if it has efficacy and safety for that. And a really important one is hyperalgesia. If anybody's come across somebody with hyperalgesia, this is a really important role that buprenorphine plays in being able to treat that hyperalgesia. When we look at who we might think would benefit from buprenorphine, it has the similar efficacy for treating the pain as other opioids, but where it has the advantage is in that neuropathic pain. And it can be used for any of the pains. We'd use another opioid, but if we look at the special populations on the right, some of the big ones, older adults, those with renal insufficiency, it is tolerated quite well and it is safe. Those that have a severe COPD, if they also have a pain diagnosis, with that ceiling effect on respiratory depression, buprenorphine could be considered. If somebody's already immunosuppressed, buprenorphine could be considered. Um, Difficulty swallowing with that sublingual provision of the dosing makes it quite easy to administer and dose. So I talked briefly about kind of that attachment. So what we use is affinity to describe that, and the lower the number, the actually tighter the magnet is for the drug, for the opioid to that opioid receptor, to the mu receptor. So as you can see, buprenorphine is very tightly bound. So why that's important to know is that if somebody's on buprenorphine, you need to use an opioid that has a strong affinity also if you need to treat an acute pain. So if somebody's on buprenorphine for opioid use disorder and they come in, have surgery, or they've had a trauma, and they need to be treated for pain, you likely need to use a hydromorphone. Morphine you can use, but it will not get over top the buprenorphine quite as well. So hydromorphone, and typically at a bit higher dose than you would normally be used to. The other strategy is to advocate to split the buprenorphine dosing throughout the day, 3 times a day or 4 times a day. Um, just working with the prescribing clinician. The buprenorphine works very well for acute pain if the dose is split throughout the day. The challenge with the high affinity with buprenorphine is if there is an overdose. Naloxone, it still works. You may have to use at a higher dose and more frequently because that buprenorphine is so tightly attached to the mu receptor. We are seeing the demonstration of the safety when we look at the opioid toxicity related deaths in Saskatchewan. You'll see the red at the top with the methadone and the hydromorphone, the fentanyl, where many of the deaths are associated. The methadone was also in the serum, in the blood, whereas buprenorphine is much lower on that scale. So we are seeing an association of that protective aspect of the buprenorphine in our toxic drug overdose death. Why does the naloxone, so if we look at Suboxone specifically, or the film or the tablet, it has naloxone in it. Why does it have it? So the naloxone, when it's taken sublingually or orally, essentially has no activity. It is simply a deterrent of snorting or using breaking up the tab to inject IV. Once the tab is altered, that is when the naloxone would become active in the body. When it's taken sublingually and goes through that process, it does not activate. It's just the way the drug works and attaches and is processed in the body. So it essentially has no activity. And it is not the naloxone. If you've ever seen a precipitated withdrawal with Suboxone being given when other opioids are on board, it's not the naloxone. It's actually the Suboxone that precipitates the withdrawal because it has that high affinity. So when it's given and somebody is regularly taking other opioids and we give a therapeutic dose of Suboxone, the buprenorphine kicks very quickly. It removes the other opioids off. That's the safety component of it. But if it's not well known how it's being prescribed and why it's being prescribed and what it's being prescribed with, then you can run into that challenge of the precipitated withdrawal. So it is a myth buster. So this is a quick reference. Because the buprenorphine strongly binds, it displaces those other opioids such as morphine, fentanyl, hydromorphone. But it's not the naloxone. Um, the sublingual tablets and films, how we administer those, not orally. It is key that it has to be sublingual, or else the bioavailability is reduced exponentially, and we do not get the therapeutic efficacy that we're seeking. So if somebody is receiving Suboxone and is still having ongoing cravings, uncontrolled pain, substance use, then we have to consider, are they taking it properly? Are they letting it dissolve for 10 minutes underneath the tongue, not eating, drinking, smoking for 5 minutes after the 10-minute dissolve? And if it's for opioid use disorder, it is important to encourage that witness dose by the provider assisting them. So the tablets, film, Suboxone, that is usually a once a day if it's for opioid use disorder. If it's for pain management, you'll likely see a divided dose 2, 3, or 4 times daily, plus or minus a Suboxone PRN dose, just for that breakthrough pain management. And then Butrans is a patch applied to the skin, and that's applied every 7 days, replaced every 7 days. And that is usually for chronic pain. And then the Sublocade subcutaneous injection is a once monthly, and that is usually given for opioid use disorder. Just for other resources, I'm just giving a high five out to the library. We have some excellent resources where the whole team can seek more information. So Dynamic Health, Lexicomp, Nursing Reference Center Plus, Nursing Central, all available through the library to every provider in the SHA and free of charge. And they can install these on their personal devices, or they're on the devices on the units. There's my references. There is a quick QR code. Stewardship, we are funded through the SUOP grant through the federal government. So if people are comfortable, please just scan the QR code, and it will be literally a 2-minute survey. And we use that just to submit to the federal government SUOP. It is completely anonymous. I saw some questions coming up there.
Yeah, there's just one in there in regards to the barriers using the Butrans in long-term care, as it's not covered. So would they have to go through exceptional drug status or something like that?
It is not covered in Saskatchewan at this point. We that so it went through CADTH review federally, and Saskatchewan follows the CADTH recommendations for covered drugs. Butrans is not covered by the formulary, but it is covered by NIHB. Same as with the sublingual films are covered by NIHB, but not formulary.
Thanks
I
for
will,
that, Leland.
yeah,